Warm welcome to one and all. As Shripriya was mentioning, we are getting to a phase where we have to know everything, nitty-gritties. So we are not going to miss anything as much as possible. So, like sometimes palliative care, what emergencies? No, everything has a role. So that is what we are going to see. If it has got a role, how are we going to manage it? For that, I welcome Dr. Vineetha Rijju, who has completed her training in palliative medicine and obtained her qualification both from Calicut and from Cardiff University, and was working at Calicut. And now she's pursuing into further studies. And so nice and kind of her to be willing to participate in teaching sessions too. And her main interest is integrating palliative care in oncology. Yes, it is an important task. Okay, with that, I welcome you, Dr. Vineetha Rijju, to take us through our session today.
Thank you, ma'am. Thank you so much. And without much delay, I think we should move on with today's topic. Let me just try to share my screen. Is my slides changing?
Yes, it's all clear. You can go ahead.
Okay, thank you. Yes, so like we were saying, emergencies in palliative care is not much actually talked about so much. I mean, we give a lot of importance of what is actually heard by most of you all is about unlearning what we have already learned in the usual way of management from way back from our MBBS days, how we were managing certain things and how we
Excuse me, dear. Sorry to interrupt. Someone has messaged that the volume is low. Is it still so? It was initially. Like, can you get closer to your mic or something, dear? It is audible, but someone had messaged volume is slightly low. Let us ask, is it still so?
If so, I might have to just take off my headphones. Is it really low?
No, it is okay now. Let us, it's okay now. Let me wait for.
Yeah, please do let me know. If so, I think last class also we faced some problem. And I think it was.
See, someone message in the chat box, if it is still low or is it okay to go? Now with the microphone held in hand, it's better. That's what it is. Keep it so, dear.
I'll keep doing that.
Thank you very much. Thank you, Dr. Chidananda, too.
All right. Yeah.
Go ahead.
So, like I was saying, there has been a lot of unlearning also that has been happening probably from the time you have been in the schools, because it's a little different from what we had already been practicing, isn't it? I'm sure all of you agree. I mean, the patients that you see are still going to be the same. I mean, the same case scenarios that we are discussing during the classes, it's probably what you have seen already in your practice. And what actually matters is that difference in principle of management that you are probably now going to make a change in applying when you look at that patient again. So, coming to emergency, so we know that in palliative care, it's there is a little bit of um, how you think about not going so aggressive in certain things, and you take just symptom by symptom. And when you actually, when the medical side actually calls it a day for the patient, and the patient is kept at home, a lot of tender loving care is mostly what is given at that point of time. So why are we actually talking about it? What is the role of emergencies in palliative care? So I would like this to be a discussion rather than me giving a lecture on this because, like I always say, these classes are always new learning for each of us, even for me. When you all share your experience, your knowledge, it is a learning experience for me, and it's a mutual give and take. So, what do you think is the role of emergencies in palliative care? Would you like to put it on the chat box, your ideas? Yes? Anybody? What is the role of palliative care in of emergencies in palliative care? Breakthrough pain. Yes, Dr. Chidananda said breakthrough. The patient is on pain medications, yet the patient is in immense amount of pain. Okay, that is severe pain. Severe pain is definitely an emergency. And at that point of time, you probably are not going to think of the step one, step two of the ladder. You're going to go straight up to the third step, isn't it? Yes, other than severe pain, spinal cord compression. Dr. Arora says spinal cord compression, absolutely. It is very important, and we'll be just going to it in a bit of detail as to why it is an emergency in palliative care when we are focusing so much on the quality of life of the patient than the disease per se. So that why are we so bothered about spinal cord compression? We shall go into that in a bit. Yes, we have other suggestions like this electrolyte by Dr. Shivakumar, then superior vena cava syndrome, then Dr. Kamashi says suicidal tendencies, Dr. Vasanta says hematemesis, yes, and Dr. Arora also says bleeding, and Dr. Chidananda says acute decompensation of respiratory decompensation, cardiac decompensation. And Dr. Shika says pathological fracture. Yes, Dr. Arora says pulmonary embolism. And Dr. Vasanta says dyspnea, severe dyspnea, acute dyspnea. Definitely. I mean, all of you are right. And we are talking about palliative care. So, one important thing, agitation. Yes, Dr. Chidananda also puts in agitation when there is electrolyte imbalances. Definitely, the patient goes into something what we call as delirium. And this delirium is definitely an emergency which we have to take care. So, having said that, let us move on further. So, we need to know what is an emergency. So, an emergency we know is it is an acute injury or illness that poses an immediate risk to a person's life or long term health. So, that's exactly what we were trying to find out. So, can there be emergencies in fact? And most of you have almost filled the list of what all are the emergencies that we see in that. So, how do we decide in palliative care? What are the emergencies? We might not be in this 1 hour session, probably we might not be able to look at each and every emergency in detail. So, what I have decided to do is we will be looking into 3 of the emergencies in detail and the rest of them through a case scenario. Okay, so what I would like to emphasize over here. Where is this slide? What I would like to emphasize over here is that you all did give me a long list of acute dyspnea, pulmonary embolism, all these, and spinal cord compression, superior vena cava, hematemesis, dyselectrolytemia, and agitation, okay, seizures. All these are different emergencies. But the way we deal with these emergencies are different in palliative care in the different folds of the disease. That is, if you can see this picture over here, we can see that in the beginning, well, palliative care starts from diagnosis. The blue color that is represented here is palliative care. The blue color says palliative care, where it progresses to end of life care, and palliative care doesn't stop there. It proceeds further as bereavement support for the family. Now, palliative care, when it starts at diagnosis, it is minimal because there the huge chunk of contribution is by the curative care for that disease. Now, as the disease becomes less curable and goes on further as to a chronic or advanced state, that is when palliative care, the role of palliative care increases. So, what I would like to stress here is that during each trajectory of the disease, the role of or the principle of managing that emergency in palliative care is when we are in the beginning of the disease where the curative treatment is applied most, we are aggressive in our treatment in palliative care. But that is not probably going to be the same treatment we are going to advise if that patient is towards end of life or is going towards his terminal days. So it is very important to know and uh, in which phase of the disease that the patient is in. So, like I said, this is what we will be looking into, three of the emergencies on how to diagnose them, how to manage them, spinal cord compression, superior vein cable obstruction, and terminal hemorrhage. And yes, these are the questions that you have to keep in mind, like a checklist rather. It's like a checklist that you have to keep in mind when you see a patient coming to you with emergency, in an emergency in palliative care. So the first question you ask yourself, is the problem that I am looking at reversible? A patient is having severe dyspnea, like you said. Okay, is this reversible? Maybe it is a bronchospasm that the patient is having, a chronic COPD patient having a, having repeated acute exacerbations of dyspnea. The patient comes to you with acute dyspnea. You are managing it. Is this problem reversible? Is this dyspnea reversible? How much? Now, is it the same like a patient who is having CA lung with pleural effusion, hemorrhagic pleural effusion, encysted pleural effusions, and the patient is in acute dyspnea, advanced disease? How reversible is it? And whatever you are trying to do, is it going to improve the quality of the life of the patient that the patient is currently having? Or is it going to maintain the quality of life? Or the quality of life of the patient when the patient is having the acute symptom is going to be bad. But before the onset of the symptom, what was the quality of life? Today, the patient is bedridden because of his symptoms. But just before that, was he able to do his routines? So, by managing that emergency, are you able to bring him back to doing his daily routines? Improving or maintaining the quality of life of that patient. What is the disease status of that patient? Like I said, the earlier case, the patient is having malignancy of the lung with metastasis to the brain, bone, and has now come to you with hemorrhagic pleural effusion and is severely dyspneic. What is the disease status? It's advanced state. What is the prognosis? It's bad. Do you put an intracostal drainage tube there? Or is it that you are going to manage the patient is really sick towards his terminal days? Are you just going to manage that patient with medications that is going to relieve his dyspnea? Now that is all your uh, your way of thinking on how to manage this. It is the protocols, the guidelines that you're following for managing a patient in palliative care for this current symptoms. But you cannot impose a treatment just because you want to do this, just because the textbook says that you have to do this. Does the patient actually want? Most of the times we tend to discuss the plan of treatment with the family. The patient is there in the room, dyspneic on his bed. We are discussing what has to be done, whether you want to do it this way, that way with the family. Outside the room, the door is closed. The patient doesn't get to hear all this. The family decides, come on, let us go for this. And the patient who does not even want that kind of treatment is having to undergo that. So you have to acknowledge the patient's wishes, the family's wishes. The patient's wishes is the most important. Autonomy, ethics, well, it is the medical ethics, one of the most important principles of medical ethics. And whatever you are going to do, you're going to put an ICD tube there for that patient. Just let all that fluid drain. The patient is in his terminal phase. The treatment that you are going to do, is it going to actually relieve him or cause more distress to him? We are talking about an intervention, poking him, a tube, every time he tries to turn or he takes a deep breath, it is going to cause him pain. Is it worth it? How much of a quality of life are we giving him? So these are, in short, the questions, very important, very, very important questions that we need to keep in our mind like a checklist before we manage an emergency in panic. So these are some of the most common emergencies that we come across. That is, like you have already mentioned, very severe pain, spinal cord compression, superior vena cava obstruction, hypercalcemia. Hypercalcemia is taken for granted, and actually we think that hypercalcemia is not common, but actually when you investigate and see, most of the times it is not that uncommon. And someone who develops hypercalcemia has a tendency to develop hypercalcemia again. So you have to be on the lookout for such patients. Delirium, like one of you were saying, agitation. Agitation is an emergency. Delirium can be hypodelirium or hyper. Then you have end of life symptoms. Sometimes end of life symptoms are so distressing for the patient that itself is an emergency. Towards death, in the last phase of death, doesn't mean that, yes, the patient has to struggle. It is inevitable. No, in palliative care, it is not inevitable. The symptoms can be made as comfortable as possible. I don't know whether you have finished a class on end of life symptom management. Probably you are going to have a class. And hemorrhage, again, severe bleeding is yet an emergency. Sepsis in neutropenic patients is an emergency. Seizures is yet an emergency. So we shall be going through each of them through some case scenarios, and 3 of them in detail and the rest of them through just case scenarios. Okay. So Raj is a 63-year-old gentleman who has been on androgen blockade for carcinoma prostate and came to you today with complaints of severe back pain. Okay, that pain score is like 9 on 10, it's really severe. And some numbness also over his both lower limbs. So he is on androgen blockade, he's having CA prostate and is on treatment for that. And now he has come to you with severe back pain. And it's not just the pain, he's also telling you about some numbness. So what are we looking at here? Yes, what are we looking at here? You can use the chat box or you can use unmute and say. back pain, numbness to the legs, patient who was having a CA prostate. Yes, Dr. Arora says spinal cord compression. Dr. Chidananda also agrees to it. Yes, Dr. Mudanuru also agrees. Yes, Dr. Kamashi also agrees. Yes, all of you do agree. We are looking at spinal cord compression because of bone metastasis, which is so common in prostate malignancies, isn't it? I'm sure most of you have seen this in movies. So that is the first topic that we are going to deal with. And this figure just shows you the different levels at which, when there is spinal cord injury, what does it result in? So something at the L1, L5 level could present as paraplegia for the patient, and someone who has a METS in from C1 to C6 and develops a vertebral collapse with spinal cord compression is likely to develop quadriplegia. Okay? So spinal cord compression is seen in about 5% of cancer patients, and 10% of patients with vertebral metastasis can develop a spinal cord compression. Now, what is most important about spinal cord compression management is that it's a very tricky situation because in the early phases of the spinal cord compression, it's very subtle symptoms. Like many of the patients, they are coming from very far off places for their treatment to the cancer center, and they have to travel for a long time in car or bus or train, and then they are coming to the center, waiting there for their treatment, and then after that again traveling the same day back. And the next time they come to you, probably they are going to come to you saying that, Doctor, I have severe back pain. This travel is actually killing my back. But what we need to know is that we have to think one step ahead. You are having a prostate malignancy patient telling you about that back pain. Always go that one step ahead and think, is he developing bone metastasis? Am I looking at the first symptom of evolving spinal cord compression? So, what happens sometimes if you miss this thought, if you miss this diagnosis, is that very commonly we tend to write analgesics for such symptoms. So, if I'm going to have a patient who comes to me saying that I'm having back pain, it is the travel that is causing me, and I overlook this and I prescribe the patient with analgesics, the patient has pain relief and now puts more pressure in doing his daily activities. More strain is coming on that bone. Next time he will come to you with numbness because the compression has got worse. So it is very important sometimes when patients come to you with certain symptoms to investigate further or make sure whether, or clinically do an examination and make sure that you are ruling out spinal cord compression. And by the time the classical symptoms of back pain, numbness of the lower limbs, everything comes and sets in front of you, it is too late. When I say too late, I am talking about reversing the situation. So by the time the classical symptoms of complete numbness sets in and the patient is not able to walk at all, it is very difficult to get back to a state that the patient will be completely normal to walk. If it is subtle symptoms and you start your treatment earlier, that patient is going to be able to walk even more faster. What I meant is in a shorter period of time, definitely. It will be a much more better improvement. So spinal cord compressions are commonly seen in multiple myeloma, cancers of the breast, bronchus, prostate, bladder, kidney. These are the common malignancies and most commonly seen in the thoracic sector. And how? What is the mechanism that happens? You might probably have an erosion. Okay, the vertebral body is having metastasis. There is erosion of the vertebral body into the epidural space. That is one way. Or there is just a vertebral collapse that happens. Or there is a spread of the tumor through the intervertebral thorax. Or there is an interruption of the vascular supply because of the tumor thrombus. So the common symptoms that the patient comes to you with, like how we saw in the case of Raj, is backache. And he tells you it is more when I lie down. It is increased in the supine position. And also complains of root pains and band-like pains, which is increased by strain. Say something like, on coughing, sneezing, severe root pain that comes from the back, from the lower back to the lower limbs. Or there could be stiffness or weakness. There can be altered sensations in the feet. And generally, it starts from the feet and up, up, up. It's more ascending in pattern. By the time the urinary symptoms and perianal numbness starts, that is, retention symptoms start, it is a very late sign and it is poor prognosis. So you can localize the lesion even without sometimes imaging that is done. You can take the history of the patient, do a clinical examination of the patient, and you will be able to come to a diagnosis of whether you are looking at a above L1 lesion or below L1. If it is an above L1 lesion, most probably your patient is going to have spastic paralysis, increased reflexes, upgoing plantars, sensory levels will tell you. The local and the radicular back pain is also typical. Whereas below L1 lesions mostly present as flaccid paralysis, and the reflexes are absent, the plantars are downward, and there are somatosensory changes, and there is also the bladder bubble, the anal tone that is involved. So you might want to take an X-ray, which is the most easily available investigation. Ideally, MRI is the investigation choice for a spinal cord compression. Why? Because in X-ray, at least 50% of the bone destruction should have happened to show you that sign on an X-ray. So investigations, you have X-ray, you have CAT scan, you have MRI, all that is there, but MRI is the investigation of choice, but very difficult. Most centers don't have the ability for MRI. Then even if you refer the patient to an MRI center, sometimes there is waiting period. Your patient with the spinal cord compression cannot wait. You have to act fast. So you have to start, if your clinical examination, history, everything is pointing towards spinal cord compression, you have to start immediately your treatment, right? So talking about treatment, what is the treatment that you are going to offer for this patient? Yes. I'm sure many of you have managed patients with spinal cord. Yes, Dr. Arora says dexamethasone. Definitely, dexamethasone is corticosteroids is one of the mainstay of treatment for spinal cord compression. Conservative treatment for spinal cord compression. Anything more? Treatment for spinal cord compression? Yes. Tapos. Treatment for spinal cord compression is what we were discussing. Any more suggestions? We have had one suggestion that corticosteroids like dexamethasone is one of the treatment that we give. Yes, Dr. Chidananda says analgesics. Your patient is in pain, severe pain. Definitely analgesics. You can take a pain score and accordingly you can decide on which analgesic step to take. Yes. Anything more? Let's go ahead to the next slide. Right. So urgent intervention is required in 24 hours. We cannot delay over here. Corticosteroids like dexamethasone. So you're right, dexamethasone is the choice of medication. And how much? How often? For how many days? Dexamethasone is given at a high dose. Okay, now here I have put at 16 milligram. Most institutions follow 40 milligram. 40 milligram of dexamethasone. It is very difficult for the patient if you are going to give an IV push. So most often what is done is that it is diluted in 100 ml and then given 40 milligram of dexamethasone IV. Okay. Now this can be, if you have to give a push, it has to be so slow, because when you are giving high dose steroids to a patient, it can cause some amount of distress for the patient, especially some kind of crawling like feeling, or they tell about, very typically they say about some crawling like sensation in the anus in the body, right? So make sure how you administer it. And some institutions follow like 24 milligram. I personally used to administer 40 milligram. Okay. And sometimes 16 milligram is also given. So this is the range basically. Okay? And it is given daily, once daily, as a single dose per day. And ideally, it is given before night. Okay. Ideally, it is given before night. And because it might interfere with sleep if it is given during that time. Okay. And how many days do you give it for? You give that high dose for 3 days. Or you maximum for 4 days. And by then you keep examining the patient, keep taking history from the patient. Are you able to get any sensations? Are you able to move the feet a little? And you check for any sensation, recovery of sensations in the limbs. Okay. So is the patient able to at least move the leg along gravity, if not against gravity? Okay. These are all the different things that we keep examining the patient all these 3 or 4 days that the patient is on high dose steroids, okay, which helps us decide on further treatment. And radiotherapy or surgery is again another treatment which is advised for spinal cord compression. And who is advised radiotherapy? Who is advised surgery? Anybody has any suggestions on that? Who gets radiotherapy? Who is advised surgery? Anybody would like to put their suggestions about that in the chat box? Yes, you have started dexamethasone for your patient, but definitely radiotherapy in malignancy, in bone metastasis, radiotherapy and surgery are the different treatment option for spinal cord compression. The corticosteroid that you gave is not going to touch the tumor. The corticosteroid or dexamethasone that you have given is only going to decrease the peritumoral edema, the edema around it. So you need to now address that tumor that is sitting there and causing the problem. For that, you need radiation. For that, you need surgery. So I get answers here, like Dr. Shikha says, radiation for pain, surgery for weakness. And Dr. Chidananda says probably it is the life expectancy, the quality of life that that has to make you decide on which for which. And sometimes when it is the tumor which is invading and eroding inside, adjuvant chemotherapy is also helpful, especially like lymphomas and all that. I've seen how the um, lymphoma tumors, they just melt with chemotherapy. And again, uh, treating patients with spinal cord compression, it's absolutely an interdisciplinary approach. So it is not just a palliative care specialist, it is the surgical oncologist, the ortho surgeon, the neuro, the medical oncologist, the radiation oncologist. You have the physical, the PMR department has a huge role there. And also the psychologist, because imagine the breadwinner of the family, who was up and about doing the routines, even though he was diagnosed with cancer and taking treatment. And suddenly he is unable to walk, he's become bedridden. The psychological trauma. So, uplifting such patients also requires psychological support, right? So it is definitely a multidisciplinary and interdisciplinary approach. Yes, Dr. Vasanta is also saying decompression or debulking of the tumor mass is surgical approach. Definitely, all these are, but when that is what the indications for surgery is. Sometimes it is the first presentation. You don't even know that the patient has a malignancy. The patient has just come to the one of the OPDs with symptom of I'm not able to move. So you will need a tissue diagnosis. So surgery is definitely an indication. If despite the radiotherapy there is deterioration, surgery can be an indication. Or if there is a spinal instability with bone destruction, then a spinal cord compression, then a surgery is definitely needed, especially if it is just one vertebral lesion where there's which is causing, then definitely surgery is the choice. But if there are multiple levels of metastasis which has to be addressed, then radiotherapy is what we advise. Okay. And if it is a spinal cord lesion, C1 to C6, remember in that figure we saw quadriplegia. So if it is any metastasis over there, we did not take a chance. We want stabilization there. So that is also an indication for spinal cord. So your spinal cord compression management is basically meant for regaining that ability to walk for the patient. 70% of ambulatory patients will be able to regain their ability. 70% of ambulatory patients, those people who came walking, telling that I have some numbness. So those 70% of those kind of patients will be able to regain their complete ability to walk. But some patients who were brought in a wheelchair saying that, it's very difficult to walk. Like I have to catch and walk, paraparetic. Now those, only 30% of those patients regain completely their ability. Now then there is paraplegic, where they are not able to move anything along gravity, nothing. Paraplegic totally. They only 5% of those patients will be able to regain their ability to walk. So now you know why it is important to address these symptoms as early as. So a long-term management of these patients with spinal cord compression would be long-term management of their mobility and spinal protection of the spinal cord, and preservation of their mobility. PMR, the physical medicine and rehabilitation, has a huge role to play, which has to be a regular support. Okay, the patients have to be taught, the family has to be taught about how to do all the exercises or whatever is being advised by the PMR team regularly. Then skin care, bowel interventions also should be adequately looked into. The patient is lying on the bed for 3 days, skin care, the back care, so that he does not develop any bed sore. Bowel interventions, if there is a retention of the urine, retention of the bowel, unable to pass stools, then interventions have to be done. Digital evacuation of the stools, enema every other day, alternate days given. For retention of the bladder, you might have to put in a catheter. Or so then you have rehabilitation, psychosocial support also. Let us again look at few other scenarios. Now this is Tej, 47-year-old gentleman who completed his 6th cycle of chemotherapy for carcinoma lung 2 months back. Okay, he has carcinoma lung and he has completed his treatment 2 months back. But now he is coming to you saying, I must say that I have been feeling as if my breath is stuck at my throat. Is it because that I have put on so much of weight? I'm just feeling so puffed up. So what are we looking at over here? Yes, Dr. Arora says superior vena cava obstruction. Absolutely. Yes. So we are looking at SVCO, the superior vena cava obstruction, and this is how your patient will come complaining of symptoms. Okay. It may not necessarily happen, after the treatment, and then there is a new recurrence of the tumor. It can happen even during the treatment when the disease has become less responsive or has become progressive in the middle of the treatment. The superior vena cava obstruction, it is caused by tumor in the mediastinum, which is preventing the venous drainage from the head to the arms and the upper trunk. This is most commonly seen in malignancies of the bronchus, but also seen commonly in lymphomas, sometimes seen in the breast, esophagus, colon, and testis malignancy. So how is it that the mechanism? Sometimes you're having the vessel over there and you're having the tumor sitting on the top and pressing it, extrinsic pressure. Sometimes you're having the tumor invading into the canal. So it's a direct invasion of the tumor, okay, and occluding. Sometimes it might be a thrombus which is sitting inside the SVC, the superior vena cava. So that is a thrombus which is occluding. Now, this is commonly seen in those patients with central lines. You might have seen that many of the patients who are receiving chemotherapy, they have very difficult venous access. So they are being advised to have a PICC line, a peripherally inserted central catheter. So this is one of the complications that we see in patients with central lines, especially in malignancy, because malignancy is a risk factor for venous thrombosis. So there can be venous thrombosis and it can also cause SPP. So this is sudden. You might see the symptoms happening over weeks or months, and sometimes it is not seen because the body is so intelligent, it just develops collaterals around it, and we might not know that something like this is happening. And what does the patient present to you with? Dyspnea, because the trachea is compressed, because if there is some edema that is there, and there is dyspnea, headache on stooping forward. This is because of cerebral edema, the visual changes, dizziness, syncope, swelling and of the face, neck, and arms, like how we saw in that example, that case scenario. Page, you were saying how there is puffiness of the face, isn't it? So how do you identify? Again, like I said before, taking a CT scan might be better, but again, if your center does not have the facility for an immediate appointment for CT, or if the patient is less affordable, maybe a chest X-ray at least can be done to get a picture of if there is a large mass sitting there, right there, and compressing the superior vena cava. Okay. And yes, there is an option of venography to be done here if you want to put your patient on a SVC or stent. Now, having a stent inside the superior vena cava is an expensive option. So, before you decide on having that stent put for your patient, you have to check the affordability, you have to check the prognosis. Okay. So again, management needs admission, emergency treatment. Again, your patient is dyspneic. So just like how you are managing a dyspneic patient, make the patient sit up. The patient is going to be definitely anxious because breathlessness stimulates anxiety. And when anxiety increases, breathlessness increases. It's a vicious cycle that keeps going. You have to break the cycle then, break the cycle. To break the cycle, you have to maintain calmness, break the anxiety of the patient. That is can be achieved with benzodiazepines. So you can give a lorazepam. What I usually do is that I place a 0.5 mg or a 1 mg lorazepam according to the struggle for this in dyspnea that the patient has sublingually. I just get the tablet and ask them to place it under the tongue. Okay. And dexamethasone is again administered here at a high dose of 16 milligram or to 24 milligram IV or subcutaneous once daily, not, before night, that is ideally before 6 p.m. And this is again like how we gave for spinal cord compression, which is given for 3 to 4 days and then tapered down. Okay. And furosemide and a diuretic also can be given 40 milligram IV or subcutaneous once daily. Do not give it at night because your diuretic is going to cause the discomfort to make the patient void, so urinate. So try not to administer furosemide. Then, of course, oxygen is important, but for who? We are talking about oxygen trial here. Trial. Okay, this is something that we usually see in palliative because we are dealing with different types of patients. Like I said before, during the trajectory of the disease, we might be dealing with patients who are on definitive curative treatment. We may be seeing patients with advanced disease in end of life care. Now, oxygen trial is something where we are monitoring how effective the oxygen is helping the patient. Oxygen is a resource which is very valuable. The use of oxygen has to be justified. You don't just let the oxygen on say 4 liters, 5 liters for a patient who is actually not getting much benefit of it. Only because the saturation probe, the pulse oximeter is going on showing a low value. You are not treating the pulse oximeter. We are treating the patient. So check if your patient is feeling symptomatically better with the oxygen. So you can give boluses of oxygen as and when in a regular fashion, if not for a continuous manner, and treat the breathlessness with opioids like morphine. Have you been introduced about the use of morphine for breathlessness? I'm sure in the respiratory class it was. So how low dose morphine can be given for breathlessness because it helps to make the patient less distressful. Now, emergency radiotherapy or chemotherapy is also very important to bring down the tumor size. Okay, SVC stents, like I said before, it depends on the prognosis of the patient and the affordability of it. Now, we come to the next topic, hemorrhage. In the event of severe hemorrhage, there is a huge bleed. You know that tumor masses are very vascular. So it is not very easy to just randomly operate any tumor that's seen. Sometimes there is a huge mass, and you think that, oh, why it can't be just surgically removed? These tumors sometimes are very vascular. The slightest, uh, the slightest of thing that happens on it can cause a massive bleed. So there is a risk for the a huge bleed in some areas. Like sometimes there's a lymph node mass which is sitting on the neck of the patient, which becomes huge, then ulcerates, fungates. Now, what is there at that point behind that tumor? There is a carotid artery, isn't it? So if this ulcer, that fungating ulcer, is going to deepen and deepen, and finally it is going to erode into that carotid artery, there's going to be a massive blowout. So when you have patients who you are recognizing that there could be a risk for a huge torrential bleed, you discuss that with the patient and the family. What could be done at that point? They're probably going to be at home. How to manage a situation like that? It may be not appropriate for patients at the end of life to be transferred maybe to a hospital, or maybe for some higher interventions like emboli. Sometimes we do like for in CA cervix and all that, where there is severe bleeding TB for patients, advanced disease, severe bleeding. These patients are given they are the uterine artery is embolized. So sometimes the patients who are in end of life, the terminal stages, dyspneic and all that, gasping for breath and all that, and then there is a bleed also. You might not want to shift that patient for a uterine embolization or uterine artery embolization, isn't it? So what else can be done there? This can be happening because not just of the tumor. In palliative care, if you're seeing a hemorrhage, do not think it is always because of that vascular tumor mass, which is the culprit. It is probably sometimes the medicines that the patient is taking, or maybe the medicines that you started for that patient. So always check, is your patient on NSAIDs or is your patient on steroids? Because these two can cause bleeding, mostly gastric bleeding. Hmm? And also, if your patient is on treatment, chemotherapy, you know that when patient takes chemotherapy, the patient does go through a period which is called as neutropenia, pancytopenia. Sometimes it is just the white blood cells that come down by after the seventh day. Hmm? But sometimes all the lineages, the HB, the hemoglobin, the white blood cells, the platelets, all the three lineages, they come down. Usually happens after a week. So is your patient having a low platelet count as part of that? Is that what is causing the bleeding? Or is the patient having a liver failure, hepatic insufficiency, where you might see that the patient, the INR is deranged, PT-INR is deranged because of that? Is that what is causing the bleeding? Or maybe your patient is having some thrombosis, SVC thrombosis, and your patient was put on warfarin. That warfarin the patient was taking was a higher dose, which now his INR is like, like 4, 5. That is causing the bleeding. Now, these are reversible. If you have an understanding of these agents can be the culprit for the bleeding in your patient, stopping it or maybe substituting it with something which has a lesser potential for bleeding can this solve the problem. So this is basically just an algorithm that I have put here on how to manage a patient with bleeding. And the first part tells you about, what could be the possible causes. Then it tells you about the multidisciplinary team discussion, who all are part of that team when you decide, and what kind of discussions you have to have with the patient and family. Okay. So what is most needed is definitely you have to control the bleeding. symptomatically, how to control the amount of bleeding. Is it just a pressure support you give, or is it some drugs that you have to give at that point? Is it parenterally that you have to give? Is it orally that you have to give? Or is it just locally that you have to give over that bleeding point? And are you going to give blood for this patient? Blood transfusion. There is so much of hemorrhage. Who are you going to give blood transfusion for? Again, this depends on which trajectory of the disease that patient is in. If that patient is undergoing a phase, is going through a phase of curative treatment, definitive treatment, is having a preserved performance status, you have to address. If that patient is in shock, you have to give fluid replace or blood products, colloids or blood products. Okay. And if you are if your patient is in that last phase, terminal, these do not have much role. It is about controlling that bleeding. Okay, so it is about how that bleeding is going to be made less, scarier. Have asked them to have dark color clothes kept around the bleeding site so that the impact of blood is less. This helps to relieve the patient and the family because it's very scary. And also how to give pressure and a psychological support for not just the patient but the family also. Okay, and sometimes terminal bleeding. This even I have done. Then during the terminal phase, when there is a huge bleeding that is happening and there is no way it is getting controlled, you might just have to sedate that patient for his comfort. Okay. Now, surgical ligation of the artery, we had talked about it. It's more during the early phases. So, otherwise, management of mild bleeding, you can give a palliative radiotherapy. Okay. And otherwise, local pressure, ethamsilate, tranexamic acid. These are very common used drugs, right? So ethamsilate and tranexamic acid, you might be familiar by giving it to your patients orally or maybe IV parenteral. But one thing that you need to know is that these can be even applied locally. So there are many times, even when I have my patients having severe bleed from their ulcers, I ask the sister to just break open a vial of tranexamic acid and ask them to pour it into a surgical pad and give a nice local pressure with the tranexamic acid on that ulcer. And it helps to control the bleeding much easier. Okay. Sometimes if it is in the home, what the patients can do, the family can do is that break down the tablets into powder form. Also, it can be sucralfate can be used along with it, and it can be sprinkled over the bleeding area. This also helps to control the bleeding. Topical adrenaline, the hemlock, prepared at a ratio of 1:1,000 is also used. So when you're having an acute bleeding in palliative care, calm the atmosphere. Someone has to be with the patient. Airway management. If it is massive hematemesis that is happening, turn the patient and make the patient lie laterally. Make the airway patent. Local control if possible, that is like pressure. If it is an area, you can apply pressure. And like I said, sometimes you have to sedate the patient. You can use midazolam, morphine, lorazepam. And then dark colored clothes, I had told you, support the family also. Because like I said before, it is very fearful for the family and the patient to go through an episode of severe bleeding. So now I'm just going to quickly go through a few case scenarios to look at what are the other emergencies that we face in palliative care. So Margula is, so here is when I would also like more answers coming in the chat box, okay? Because I have not prepared in detail about these case situations, because these are the situations where we might just be discussing it. So Margula is a 46-year-old lady on oral capecitabine. Oral capecitabine is a chemotherapy drug, okay? And she's been given that for her locally advanced CA breast and skeletal metastasis. And she's been brought to you with confusion. She has also been eating less and she has severe nausea and vomiting. Okay, CA breast with skeletal metastasis, confusion, severe vomiting, nausea. What are we looking at? Any idea? Stricture, I have answers here. Stricture, hyponatremia, hypoglycemia. Yes, Dr. Deepa, Dr. Aurora give suggestions. Dr. Imthia says, is it brain metastasis? Yes. Anything more? Well, we have only these many details here, isn't it? So with the limited details, definitely there is a lot of diagnosis that we can, provisional diagnosis that we can come to. So what are the differential diagnoses here? I got answers like electrolyte imbalances like hyponatremia, hypoglycemia, brain metastasis. Dr. Kamakshi says dyselectrolytemia again. Yes. Metastatic disease, Dr. Chitananda says a drug side effect. Is it the capecitabine which is probably causing it? Yes. Delirium, Dr. Kamakshi says delirium. Yes, it's probably maybe drug induced or the electrolyte imbalance, which is probably causing the delirium. Yes, Dr. Deepa says the deranged liver function also, which is attributing to metabolic imbalances, which is causing the delirium, the confusion in the patient. So basically here, what I was intending to come out, like I said, this is only very limited points that I have put out over here. Only by further examining this patient or doing certain investigations, I will be able to pinpoint, or you will be able to pinpoint, saying, okay, this is the reason. Till then, we can only work along some differential diagnosis, isn't it? But I had put up this case history over here to particularly talk about hypercalcemia, which is very commonly seen in patients with skeletal metastasis. So if you have a patient with hypercalcemia, this is what your patient could probably present with: nausea, vomiting, confusion. Always try to make sure you check if the patient is having hypercalcemia. Check for the ionized calcium levels. If you look for the serum calcium levels, it might not be accurate because it is dependent on the albumin, the serum albumin level of the patient. Any imbalances in the serum albumin level of the patient will reflect on the value of serum calcium. So looking at the ionized calcium levels will give you a more clearer picture. So if your ionized calcium level is high and you find out, okay, this is hypercalcemia, what is your first management? What is the first thing that you would like to do? Your management for hypercalcemia. IV fluids, exactly. Dr. Aurora says IV fluids, push IV fluids for this patient, 3 liters per day. Okay. Also watch out that you are not overloading the patient, because at the same time you're trying to also give some amount of diuretics. You do not want the patient going into a cardiac failure. But mainly IV fluids is the first line of management, and then we move on to the next line, which is bisphosphonates. Bisphosphonates, most commonly used is zoledronic acid, 4 mg zoledronic acid in 100 ml of NS, IV over half an hour. In some institutions, they give a pre-medication of dexamethasone. A 4 mg dexamethasone IV is given before administering that zoledronic acid, because sometimes zoledronic acid itself can cause hyperalgesia. It can cause increased pains all over the body, or sometimes it can cause uh, fever like symptoms. So to avoid that, dexamethasone is sometimes given like a pre-medication before administering zoldronic. Now, once a zoldronic is given, you cannot repeat it every day. You have to wait for 3 weeks before you can administer the next dose. Whereas if it is calcitonin, you can give repeatedly. Yes, Dr. Shikha says calcitonin. Calcitonin can be repeated until you can bring down the level of calcium. Yes. IV fluid of choice would be NS. Okay. Now, yes, other than that, also we need to know, keep in mind is that once your patient has presented with hypercalcemia, there is always a chance for again developing hypercalcemia in that patient. So and if you have given bisphosphonates, you have to wait for 3 days to again check the ionized calcium level to see if it has made an improvement in the level. There is no point in checking 3 times a day the ionized calcium. Right. Now the next case scenario, Shanta, 47-year-old lady with carcinoma ovary recurrence. Okay, she's also on some chemotherapy, topotecan, and she has been complaining of severe pain, and you had started her on step 3 analgesics, so probably morphine. So one day later, she is brought to you with irrelevant talk. Doctor, you prescribed my mother heavy dose medications. Now she seems to have lost herself. What are we looking at? Yes. What are we looking at? You just prescribed a step 3 analgesics like morphine. And then the next day, her daughter comes and tells you she's talking irrelevantly, she has lost her mind. CA ovary on chemotherapy. Yes, no answers. I don't see any answers in the chat box. Yes, so here we are looking at, we need to brief them regarding these effects of morphine, which is for the only for few days, right? And otherwise, Dr. Vasanta was saying that it could also be hepatic encephalopathy. We do not know. We'll have to investigate. Like I said, these case scenarios are giving you just very minute details, isn't it? It is not giving you a lot of details to pinpoint and say, okay, this is this. So I just brought out this case scenario to just discuss about opioid-related delirium. So opioid-related delirium usually is, it passes off after a few days. So the first few days, if the patient is being told to have, a very a delirious kind of behavior, it doesn't mean that morphine is not suitable for this patient. Try control the delirium with conservatively with medications. You can use antipsychotics like haloperidol, low doses, and you can try see if you have to, control if it is getting controlled. You can bring down the dose of morphine, but also add in another analgesic to compensate that. Like sometimes, when the patient is on 10 milligram, I might try to like bring it down to 5 milligram and increase the paracetamol to 1 gram for 6 hours. So there have been times that I have done that also. But generally, these things wear off in about 2-3 days time. And still, if it's persisting, maybe you can try opioid rotation. You can change the patient from morphine to maybe fentanyl. Okay. Now there's another case, Beena on chemotherapy for carcinoma breast post her first cycle of chemotherapy. On the 8th day after her chemotherapy, she comes with severe tiredness and she is having high fever. And you also notice some rashes over her body. What is it? Yes, Dr. Arora says we are looking at neutropenia. And if to be a little more specific, what neutropenia? Neutropenic sepsis, isn't it? The patient is in neutropenic sepsis. Well, there is another differential diagnosis that is here in the chat box: Stevens-Johnson syndrome. Okay, SJS may also present with severe rashes all over the body, but here specifically we are looking at a very important point. This is around the 8th day of the chemotherapy. If your patient is undergoing chemotherapy 1 week from day one of the chemotherapy, your patient is most likely to develop neutropenia. Now, how much of neutropenia that the patient develops depends on what drug he or she has received. Sometimes some drugs need not cause severe neutropenia, but some drugs like paclitaxel, docetaxel, they all cause severe neutropenia. Yes, so how do you manage? You have to first draw cultures of the patient, blood, urine, throat swab, all these cultures of the patient, send it for culture and sensitivity, and empirically start broad spectrum antibiotics for the patient. Start it right away. But before you start it, cultures have to be drawn. And if your patient is improving on those empirical antibiotics, you need not probably change your antibiotics. Just go on with that, even if your culture sensitivity report come in a few days. Okay. But if your patient is not improving, you take your culture reports and immediately you change your drugs according to the most sensitive. Okay. And sometimes once your patient does develop something like this, the next cycle onwards, they will be advised to take by before the neutropenia sets in, the patient is advised to take granulocyte colony stimulating factor injections, okay, like filgrastim. Yes, so that brings us to the end of today's topic discussion, that is emergencies in palliative care. Any questions?
Is it connectivity issue on my end? I don't hear any.
No.
No,
They're all very absorbed. Thank you, Dr. Vineetha. Someone has a question.
Yes,
just can we come out of the screen, please?
Yes. Let me just stop. Yes.
How aggressive should we go when goals of treatment are established? That is one thing. And then I think there's another question. How do we taper the dose of dexamethasone in spirivenical obstruction, and by how much?
What I usually practice is that for spinal cord compression, 40 milligram of IV of dexamethasone is given as single dose for about 3 days or 4 days. And then after that, if the patient is showing signs of improvement, the patient is also being taken for radiotherapy, then the patient is being tapered and the patient is put in lower dose of steroids because even the radiotherapy might induce some amount of edema. So the patient is put on low dose steroids until the completion of the radiotherapy, and the patient has completely regained the ability to walk. So say if it is 40 milligram, straight off I usually go to, after the third day, I go to 8 milligram IV OD. And then slowly from that, I go down after about 3 days or 4 days to 4 milligram IVOD. And that 4 milligram goes on. And when I want to stop that 4 milligram, I taper it down to like alternate days and then stop.
So from
And
40 directly we taper to 8 mg, or we go like 24 mg, 16 mg?
no, well, usually I practice like this. Radha ma'am, you have any?
I would say, these are things, local guidelines, whatever
Hmm.
you have, you follow will be the best. Because there'll be some regional guidelines and things. Like go that high dose, high dose short time. See, even in sepsis we do.
Hmm.
So those things, that is given to tackle it's like an emergency management there. And then once, like after 3 days, going to 8 is very much okay. Because what is given, even in any, I was just giving an example of sepsis, because sepsis is something which all of us may be seeing, and in intensive care and things, where we use high dose steroid for 3 days, 5 days, and then you come down to 8 milligram. And then after that, tapering is like a normal tapering, what you would advise. So I would also agree with Dr. Vineetha's thing. And next thing, what I said is, based on your regional, if already you have regime given, like, because many hospitals and institutions nowadays have guidelines and protocols, so that mainly guidelines and protocols are to help everyone stay in the same boat. This query, that is a main important use of protocols and guidelines. In emergency, when all our heads may not be working similarly, that's where guidelines, this ALS, ATLS, all these things are there. Like main aim and objective is that. So if there is any local guideline, please follow that. Or you can use this. That is what I would say.
And I think if we even continue for a little longer, that is when we have to actually taper it, because then there's a suppression in the cycle and all. So
see, 3 days, see, same thing we say for many medications. See, for example, NSAIDs. Generally, we say no. But we use it as an anesthetist. We use it, in fact, even intravenous when need be, as 1 dose, 2 dose. That is not harmful. Their risk-benefit ratio. Like that only, you use this high dose to tackle that situation. And then at the earliest, you come down. 3 days
like
is ideal,
so
because symptom, you see the patient, clinical review again and again is what will help.
Like what I was trying to say is that there are some treatment regimes in, say, like multiple myeloma and some lymphoma cancer treatment regimes, where pulse dexamethasone is given. Pulse dexamethasone, where 40 milligram of dexamethasone is given weekly once. So it is given like for example, every Monday. Like that. So in those cases, we don't even have to think of tapering.
Yes.
So
that's all. So the next question there, if you go ahead with the next question.
How aggressive should we go when goals of treatment are established? I think once the goals of treatment are established, it is very easy. The problem is that the goals of treatment is hardly established. So most of the time, what happens is that the treatment, the decision makers, like the son who is financing the treatment and all that, they are abroad. And all this conversations are happening telephonically to the relatives who are there in the hospital with the patient. So the goals of treatment are not correctly conveyed across. And they are keeping on asking the middle person to tell us to keep going aggressive. That is where the whole thing becomes so complex. So I think once the treatment goals are established, we are not going to go aggressive beyond this point. We are not going to add any more new medications after this point. Then the family also understands under what intention we have told like that. It is for the benefit of the patient we have told like that. Then I think um, we don't have to go further aggressive. I hope
Exactly.
I have.
If goals are established and you have a nice rapport with the family, you're all in the same page. And many times, no, sometimes when patient is getting sicker, it is our duty to pre-warn them also. What can you anticipate? And if these things, give a rough idea. You need not give full protocol, what will happen, how will happen, everything. You just tell them hint, and if they ask something more, then you go ahead and explain. So those type of things, you are preparing them. And if goals are already made, then always making sure the patient and the carer and the family, they are all kept comfortable. Patient kept comfortable with symptomatic management. And then the carers by awareness. And then the whole family, so that you're giving them an assurance that you're there to help them at all times till the end. Dr. Chidananda, you have raised your hand. Can you unmute and ask, please?
Same thing. I think that's where how we communicate with the family. Go and tell the family, yes, patient is having respiratory distress, will need intubation and ventilation. The family under stress, they will accept that. But after 48 hours, 72 hours, when there is no improvement, then they start blaming the whole system. You told like this, now there's no improvement. I think that's where the way we communicate with the family, giving them, yes, this is looking at this type, what are the options which are available, and considering his overall outlook, what we offer them, that makes a lot of difference in how aggressive we go. That's what I feel.
For that, thank you, Dr. Chidanand. For that, I was so impressed the way Dr. Vineetha started today. Okay. The whole thing is that you have this patient. This is the issue. What is the preliminary condition of the patient? What is the preliminary condition of the disease? What stage is the patient in? And then you see the situation. See, that is what you need to know in entirety as much as possible. Even if you're seeing the patient first time, you do what is needed, but pre-warn them. See, I'm seeing the patient first time. I have to gather all the information. I'll come back to you. So that is more important. As Dr. Chidananda brought today, if you have a patient, you have 80% chance of patient not coming out of ventilator. I would say it is wrong to put the patient on ventilator in the first place.
Yeah, that's right. At that time, how we communicate to them.
That is where your skill, knowledge, everything comes. Your what is the benefit of this course? Your knowledge, all of you have. Okay, all of you are experts in your own field. You have the knowledge. Okay, additional supplemental knowledge of palliative care. And then the communication skill is the biggest asset all of you are gaining with this. Okay, all of you know everything. How do we say? What do we say? And in the communication sessions 2 days, we were taught you prepare the patient, you tell them, make sure every time you tell whether they're understanding. All what you have learned, put into practice, nothing more will be needed. So that is important. Yes.
Yeah. Like Madam said, absolutely. It is a combination of all that, your knowledge, your skill, your communications, everything is important. But also, I have mostly noticed during my practice that, even if you are trying to like mellow down your tone and with your modulations, your non-verbal communications, everything is going perfect in communicating to them about, not to go aggressive or not putting the patient into ventilator. But yet, what the patient wants to know, if I don't put this patient, my mother or father, on the ventilator, how else are you going to manage his or her symptom of distress? That is what. If you are going to tell, we are going to use medications such as diazepams, or maybe you need not tell exactly each and every dose or anything, but we have medications to which can bring down the dyspnea of your father and mother. It might not reverse the condition, but symptom we will definitely address it. He will be comfortable. That is what we are trying our best. I think these words of reassurance will definitely be very powerful.
It's not like
Exactly true, dear. That's what we are there to look after them. Go ahead, Dr. Chidananda. I think you.
this is what rather than putting it as the patient needs this or your kith and kin needs this. What we can, I think what the way we should put it across is what this means. These are the options. Considering this this thing, this is what we feel are the best. We should, I think, so there are two ways of communicating here. One is the paternalistic attitude, where you come and tell, okay, what is this thing option, the best option, and what is where you give the options to them and ask them to come out with their option. But I think that's where when you leave them the options, they get into a dual this thing, and nobody will be willing to let their kith and kin suffer or anything. Well, I think when we take that paternal stuff, I feel under my concern, this thing, if it was my own kith or kin, this is what I would have opted. I think that makes a decision making easy for the family and sometimes of these emergencies. That's what I feel.
I think it also depends on the family, their how much they know, their level of education, things like that. Allowing them completely to take over. There is something which is called as soft paternalism. Okay, soft paternalism, where we try to give our knowledge to them and then allow them to take their decisions. So I feel,
That's what I was trying to put it.
That's what we call it as. It's a medical decision. It's not. We just try to tell them, see, don't worry, don't think that you are not doing anything and you're not, you would love to do, but we say in this, like for example, these are all evidence to say that in this stage there is 80% chance of not coming back. And in like 30-40 years of practice in intensive care, this is what we have seen. So you give them all the information and tell them it's a collective medical decision. And they are not deciding to put them on or not to put them on and causing trouble or refusing treatment for them. All these things we have to explain. If you do that, then give them a little bit of time. And then that time means not this. Couple of, like, you give them, go sit, talk and come back, because you have gained all this. Everything is very high level sensitive information. Give some time, then they will come back. Then they'll come back and say, oh, you do the best, so that will keep my father or mother very comfortable. They should not be in pain. They should not. Then they will tell all what. Then we'll say, yes, exactly this is what we said. So all these will be taken care of. And we will provide you help and assistance, even if it's not getting better, you're going home, that also will be done, is what has to be said. Okay.
Symptom management assurance, that is what people, I think, feel people look at that.
Exactly.
Rather than your high-end equipment or what is this, the symptom management, what is, I think the families look at.
Definitely. Okay. Everything has to be documented periodically, no doubt. Even last time I said, every discussion, every change, you did this, then you changed it, like n number of times. Every hour you speak to them, you document every hour. Everything has to be documented. Black and white is what will help. So can we go on to the case discussion, please?
Yes, ma'am, sharing the screen in a while.
Actually, Radha ma'am.
Yes,
I have
heard,
to leave
I am aware
today
that you have to
early.
leave.
Yeah.
Don't worry,
Sorry.
dear. No problem.
Thank
We
you for
were
taking
aware
over.
of it. Thank you very much, Dr. Vineetha. Excellent information and very good approach you did. Thank you. Thanks a lot.
Thank you to all the participants.
Madam,
And thank you so much,
very lively
all
discussion.
Thank you, Dr. Vineetha. Hoping to see you again in future sessions. Thank you so much.
Thank you. Radha ma'am, please continue.
No problem.
Bye.
Thank you.
Bye.
Okay, we can go ahead with the presentation, dear.
Good evening, everyone. Good evening, ma'am.
Yes, please go ahead, dear.
Ma'am, I'm Dr. Kanchana. I'm a senior resident in Department of Pathology in Gayatri Medical College here in Visakhapatnam, ma'am. I shall present a case. He's a 56-year-old male patient who was diagnosed to have a chondrosarcoma of the left iliac bone with suspected malignant spinal cord compression. Presenting complaints, he had severe constant dull aching pain in the left flank since 1 year, and also complained of a sense of heaviness which worsened in both the lower limbs, and also shooting type of pain and burning sensation which radiated to the sole of his left foot, and burning sensation and incontinence of urine since 1 day. A history of his illness, he was diagnosed to have chondrosarcoma of left iliac bone, and he was under treatment at a government hospital in Vizag here, and he has undergone 6 cycles of chemotherapy and 12 cycles of radiation. He was already on tab morphine when he was admitted here on 20 mg per Q4H, but he was not taking the medication regularly. Patient also had fears of tolerance with morphine, as he said, and treatment ended, that is chemotherapy and radiotherapy both ended by November 2022. And patient was presently, like when the patient was admitted, he was referred by treating physician in view of severe pain. Next slide. History of his illness, the patient was referred in view of severe pain, and home care team found him unable to even turn on his bed, and is in a very poor state of health as he was already also having bladder incontinence. Patient complained of severe 10/10 dull aching pain in the left flank without any radiation initially, and had to remain in supine position throughout the day, and aggravated on sitting or supine position. No diurnal variation, but it has got better when he took morphine, but worsened later on. He had history of reduced oral intake, poor sleep due to pain initially, used to work at home, but now his activities of daily living has gone down since the past 2 months. After the patient was brought to hospice by the home care team, he was started on morphine 20 mg and increased to 40 mg, and pregabalin was also added along with metrazapine. Patient reported improvement in pain, but he was also able to move about. However, complained of sense of heaviness in both the limbs, and also sense of unable to lift his upper lower limb while walking, along with burning sensation of urine and urinary dribbling at times, not associated with activities like cough since 1 day. On examination, patient was conscious and coherent. There was no icterus, pallor, clubbing, cyanosis, or edema. His CVS was normal, no murmurs or no added sounds. Motor examination, power was 5/5 left lower limb and 4/5 right lower limb proximal muscles. Flexion of toes, ankle and knee joint were present, and restricted movement of hip joint on the right side was observed. Sensory findings, pain on movement of hip joint decreased, touch and position sense were normal. Treatment and significant investigation, he underwent radiotherapy and subsequent chemotherapy. His CBC levels, HB was 10.4, total leukocyte count 7,500, and platelet count 3 lakhs. X-ray pelvis showed a loss of contour and abnormal overgrowth of the left iliac bone, which showed lytic lesions, and CT of LS spine showed features of chondrosarcoma again, and MRI of the spine showed a heterogeneous lesion involving the left sacral ala, showing significant cord compression. These are the pictures which showed loss of contour and also lytic lesions in the bone. Next slide, please. Coming to the psychosocial aspects, he was a manual laborer and was the only breadwinner of his family. He got separated from his wife and 3 children 20 years ago, and now he is living with his 70-year-old dependent mother. And he went several times to visit his spouse and children. However, they were not willing to meet him. He has no financial support, and his mother was taking care of him. He's a Hindu and feeling sad when thinking of the past and feels helpless and lonely all the time. He was started on Pantop 40 mg and dexamethasone 80 mg BD stat, followed by 4 mg BD for the next 5 days. And he was also started on calcium, morphine, metrazapine, 15 mg HS was given, and also pregabalin 100 mg BD, also on citralca and sucralfate. Main concern was inability to sit or walk, severe back pain, urinary incontinence, and feeling helpless and lack of meaning in his life. To summarize, he's a 56-year-old patient diagnosed with chondrosarcoma of left iliac bone with probable impending metastatic compression over the sacral nerve roots due to metastasis, causing hemiparesis, bladder incontinence, and feeling helpless as he feels he's burdening his mother. Points of discussion. What's the importance of early identification of spinal cord compression and need for suspicion in malignancies involving the pelvis and other bony mets? Possible precipitation of spinal cord compression due to pain relief, or is it due to I just want to know if the precipitation is due to compression or pain relief or movement. Would early caution and bed rest prevent emergencies? And duration of steroid requirement, I wanted to know, but that question was answered. And outcomes of spinal cord compression. Yes, ma'am.
Thank you very much. As you said, no, like, thank
Dr. Radha?
Ma'am, I couldn't hear.
Can you hear me or not?
Now, yes, ma'am.
Now we can.
Okay. So initially, I think I was muted. So basically, thank you very much for bringing an appropriate case. Why? That's why we say these case presentations are so helpful, because some of the queries what you brought, you yourself, as you said, no. See, earlier, again and again, the whole time, what Dr. Vineetha was telling us, if you pick it up too late, it's too late. Nothing can be done. So the thing is that he got into hospital, and then pain relief and steroids always started. And then you yourself mentioned that he had some improvement too. So that is important. And then that is the first part of your thing. Possible precipitation. See, everything, the disease, you have seen the investigations, and avoid excessive strain, and then keep him in a condition reserved if possible, so that you give the pain relief and management to take him through the condition. Early caution and bed rest prevent emergencies. That we cannot say, because it depends on what is the etiology for the emergency, no? So if it is a metastasis, or if it is the spinal cord, or it could be a vascular one. So all your answers come from the session itself. And duration of treatment with steroid, exactly we discussed. Outcomes of spinal cord compression also, she had an entire slide. How much? That is why early picking up is important, because nearly when how they were before, and 30% they may not get up and walk. So roughly what all the answers for outcomes of spinal cord compression were dealt in detail with the thing. Physical aspects here with him, no? Him having a long drawn
Dr. Radha? Is it only that I lost you?
Can you hear me or not?
I lost you for a few moments. Not sure if it was the connectivity from our end, ma'am. So
No, that's all. If you could come out of the screen, I thought, so that you will be able to. Can you all hear me now?
yes. Yes, Dr. Swami also was not able
Uh,
to hear you for the past 3 months.
Oh, sorry. Because maybe it's my connectivity or what, I don't know. Because my connectivity is always showing full internet Wi-Fi. It's what it's showing. But I anyway know all these things. There's no 100% in all this. Everything can deceive us. Okay. So basically what I was trying to say is, generally management in detail we have gone through. What is the cost for it? It could be from metastasis or vascular cost. So we have seen the cost. And then management, we have seen steroids in detail. Also, I was trying to say, what level is the compression and what is the condition of the patient prior to compression. So everything matters. So putting everything together only, your outcome is going to be. So because if the outcome is not very good, it as early as possible. Coming to the psychological issue, 20 plus years. So getting to have some proper count.
So sorry, ma'am, we are losing you.
Oh. Shall I
just
go
switch
out
off the video and then try?
Yes, I will switch off the video and try. Is it any better now?
You can continue, ma'am, if again it is...
Yes, it is something you say. Okay, yeah. So basically, psychological, having a proper counseling for him separately and the family separately, and putting the importance of his condition to the family and making sure that they don't repent afterwards. So that is something has to be attempted. And then then see if they could meet. So for that also, if some effort could be taken, it will be nice both for him and the family. That is something, because the mother is an elderly person who's looking after him. She also may need some respite care. Oh, he is no more. Okay. So that's all. So these are things, okay, even for this patient, it was not possible, but something like this you have to have in mind when these type of long-term issues are there, because afterwards both may feel bad. So you don't give room for that uncomfortable feeling to linger on all through the rest of their life. So something like that, if could be possible, can be done. Anything else anybody else wants to add on? This euthanasia is a very strong thing to say, because if for especially that one, no, in a wrong way, that is why it's not allowed in every part of the world. Because see, ethics and humane values, what is the that everyone follow? Is the world good?
Should not be a this thing. We should be looking more at a comfort care. Maybe that is what
exactly.
we should be looking at it.
Exactly, that's what. So
There's
because
a very thin line between euthanasia and comfort care. How we go ahead, like suppose we put up a patient is terminally ill, we start a morphine infusion for the patient. So depending, you start at 1 milligram, patient may feel comfortable, but the same thing you go to 10 milligram in the next 1 hour,
correct,
that may not be there. So there's
exactly it's a fine line. But the main thing
which we need to discuss and document basically what you discuss with the family. Yeah, that's what I feel. Hello.
This euthanasia is not something all of us should take it from here. Again and again, good that this was brought up. I was also thinking, even what I said yesterday, no, like, see, we have to tell everyone that death is also a phase of life. Like young, yeah, like a small baby, adolescent, adult. Not what we are trying to do.
Yeah, what should be
Okay.
followed is dignity in death. That's all. That's not.
Exactly. That is all. So it's a natural process. You don't see again. I will come to those 4 ethics only. Autonomy, do good, do no harm, and then resources. So justice. So all these 4, if you read those 4 properly, this doubt of euthanasia itself will never come. Okay, so that is important. Dignity to death, dignity in the face of death also. Other than that, who are we to anybody else's? If that was done to us, will we accept it? Put yourself in the patient's shoes always. So, and then none of us have got any right in that way. Our profession and ethics have to be followed every second. That is the most important thing. So that is what has to be done. So every time, no, you have to make sure that symptomatic relief, every symptom which can be correctable. What cannot be corrected, we cannot do anything. There you go. But if you don't correct the correctable, that is not fair. So many times, nausea, vomiting, pain, these are things controlled, then everything, nature takes its way. And teaching them self-care for the patient and the attenders. Those are things which we are trying to say. And for the patient, just listening, giving another helping hand. Many times listening, and again, like as in our previous session, silence is an answer. Silence is medicine also many times. Many times they don't want, see, they tell something. Like I think last time when I came, vent it out. They are not asking for any answer from you. They don't have anyone to vent, or one of the person whom they can listen to them. So you are just a person there required to listen to them. So everything matters.
Give them the shoulder to cry.
Exactly. Yes. So empathy, sympathy, everything is important. Where which comes and takes a priority matters. So that is collecting everything together and then implementing it. Okay. Anything there in the chat box also. Oh. Shipra, in that case, I will pass it on to you.
Thank you, madam.
Thank you, ma'am. Thank you, everyone, for joining in for the day. We will see you in the next session. Till then, everyone, take care. Keep spreading happiness. Take care. Bye-bye.
Thank you.
Thank you. Thank you, one and all.